Welcome to the American Indian and Alaska Native Behavioral Health webinar series presented by the National American Indian and Alaska Native Addiction Technology Transfer Center. I'm Karen Summers and I will be administering today's webinar. Today, Dr. Peter Nathan will be presenting from DSM-4 to DSM-5 significant changes for treatment or for substance abuse professionals. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. The National American Indian and Alaska Native ATTC is one of 4 national focus centers which serves the ATTC network. The ATTC network is a nationwide network made up of 10 regional centers, 4 national focus centers, and a network coordinating office. The map on this slide shows the states served by each of the regional ATTCs. To learn more about our center, the network, or your regional center, please visit our website. Our next webinar in this series is scheduled for Wednesday, November 6th, where Ken Winters will be presenting on adolescent neurobiology and marijuana use in his presentation, 50 Shades of Developing Gray Matter. In addition to this webinar series, we offer another series entitled the Essential Substance Abuse Skills Webinar Series, which provides an overview of competencies from CSAT's TAP 21 publication, Addiction Counseling Competencies. The next session in our Essential Substance Abuse Skills series will be held on October 16th from 1 to 2:30 Eastern Time on group counseling. For more information on our webinar series, you can contact me at the email address or phone number provided on this slide. Our center is a NADAC certified educational provider, and we're happy to provide you with CEUs. The cost is $10 to do so. The CEU request form, along with a copy of today's PowerPoint, will be sent to you within 24 hours of today's session. If you don't receive the email with handouts within 2 business days, please let us know. In addition to the PowerPoint handout and CEU request form, a link to our GIPRA evaluation will be included in the email you receive following today's webinar. We invite you to participate in this brief online customer survey. The survey asks about your satisfaction with the event and will take less than 10 minutes to complete. GIPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. SAMHSA uses information collected by these surveys to determine how many people have attended our events, your satisfaction with our events, and how useful our events are to you. We hope you will assist us in gathering information about our services by participating in our evaluation. Before we start today's session, I'd like to give you a quick overview of the GoToWebinar system. To hide or expand your toolbar at any time, you can click on the red arrow in the top right side of your window. To expand your screen, click the middle button in the top right-hand corner. You will be muted for the duration of this webinar. Please use the question chat box to share your questions and comments. Your questions will only be visible to me, the webinar moderator. I will pass your questions along to the presenter at appropriate points in the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEUs received. The opinions expressed in this presentation are those of the presenter and do not necessarily reflect the official position of CSAT, SAMHSA, or the U.S. Department of Health and Human Services. Today's webinar is presented by Dr. Peter Nathan. Dr. Nathan is an extensively published author and contributing editor to the Diagnostic and Statistical Manual. He received the Association of American Publishers Psychology Award for his publication, A Guide to Treatment That Works. Dr. Nathan is a University of Iowa Foundation Professor Emeritus and contributes as a member of Special Emphasis Panel for the NIH and NIAAA, as well as special review committees for NIDA and the NIAAA. Please join me in welcoming Dr. Nathan.
Thank you. It's very good to be with you today. Let us begin. Okay, and then I'll do this. Okay. So let me talk about the DSM-5, which just appeared in May of 2013 it was in process for a number of years. It's the standard diagnostic nomenclature used in this country and in Canada and a number of other countries. The other standard diagnostic nomenclature is the ICD-10, which is used in Europe. The DSM-5 makes it possible for mental health professionals to determine first whether their clients meet the criteria, in other words, show the symptoms for one or more diagnoses. And if they do, the nomenclature reflects on what those diagnoses are. These diagnoses generated by the DSM are the only ones that are currently recognized by third-party payers like insurance companies, federal agencies, and the like. Some of you use the DSM extensively, others of you do not. Someone else is charged with the diagnosis. But I think all of you find the whole question interesting and worth getting to know better. Now, as you can see from this slide, the chronology of the DSM goes all the way back to 1952. The first one was published in 1952, and it was a very different nomenclature from DSM-5. It was about 130 pages. The trim size was a lot smaller. I think it was 5 by 8 than it is now, and there were something over 100 diagnoses included, and now the number of diagnoses is well over 300. This, however, was the first national nomenclature, the first time that psychiatrists and other mental health professionals could use a system that permitted them to hopefully agree on diagnoses when they talked about patients. Unfortunately, both DSM-1 and DSM-2 didn't contain a lot of description of the symptoms for those 100 diagnoses, so that as a result, clinicians did not often agree. But when DSM-3 was published in 1980, a whole new system had been instituted to increase the reliability of diagnoses so that clinicians would agree with each other. And that was the lists of symptoms that are included, the so-called diagnostic operational criteria, and the means of integrating those. So from DSM-3 on, the reliability has been a lot higher. There's been a lot more agreement among clinicians. That is not to say there hasn't been quite a lot of criticism of the diagnostic manuals. Criticism because of the proliferation, the dramatic increase in number of diagnoses, so that DSM-3, for example, had almost 3 times as many diagnoses as either DSM-1 or DSM-2. And the increase in number of diagnoses was even greater for the child and adolescent disorders. And so people accuse the drafters of DSM-3 and DSM-4 of unnecessarily and inappropriately increasing the number of diagnoses, thereby labeling lots of behaviors that had never before been considered psychopathological, labeling them as mental disorders, things like reading disorder, stuttering, mild depression, and the like. So that's been one of the big criticisms of the DSM. Other criticisms include that there weren't very many clinicians other than psychiatrists who were involved in creating DSM-3. There were more of others like psychologists and social workers, psychiatric nurses, and others involved in the creation of DSM-4, but DSM-5 went back to utilizing mostly psychiatrists. That limits the generalization possible from the diagnoses. Criticisms have also included the relative lack of empirical data in support of the diagnoses, and the observation that starting with DSM-3, the drafters of the DSM have tried very hard to reassert the medical neuroscience origins of the fields, the mental health fields, without the requisite data to support that. All of these criticisms and more have been attached to DSM-5. I think it's fair to say that DSM-5 has been criticized more widely by more people than any of the other DSMs. In part, that's because one of the principal critics of DSM-5 is Alan Francis, who was the chair of the task force that developed DSM-4. So that was attracted a great deal of attention. Francis has a great deal of credibility, and he's been writing criticisms, publishing them in the New York Times, and the Washington Post, Psychiatric News, and other places for many years. And he has a book that he's published called Saving Normal that appeared early in 2013. But there have been other books, there have been lots of other criticisms, and I'm personally not sure what's going to happen to DSM-5. It is the current diagnostic nomenclature, and that's why I'm talking about it to you today. But the question remains whether it's going to continue to be the accepted nomenclature or whether something else is going to take its place. Now, I've talked about reliable diagnoses and the fact that DSM-1 and DSM-2 did not contribute to reliable diagnoses. DSM-3 and DSM-4 and DSM-5 did. And what's the importance of reliable diagnosis? It's the basis on which experienced clinicians can agree on diagnoses. So if a diagnosis or a diagnostic system is not reliable, then clinicians who give diagnoses of a particular individual will not agree, will tend not to agree. And that makes communication among clinicians very difficult. So that's been one of the aims of the DSM process. Reliable diagnoses are essential for, as you see, they're supposed to guide treatment recommendations, but that's been a criticism of the DSM. Even though the diagnoses are reliable, they don't always lead to the most appropriate and effective treatment. And you know that from your own work. Often you will base a decision on recommending treatment to the other things than the diagnosis, like associated comorbid conditions like depression, anxiety, and the like. Reliable diagnoses are also useful and important for identifying prevalence rates. How many individuals with this particular diagnosis are diagnosed within a given time period? When people do research, they want to make sure that they have homogeneous research groups diagnostically, and that depends too on reliable diagnosis. And then there are such important public health information systems that comment on morbidity and mortality, and again, you need to be able to be reliable in your diagnoses. So those are all good reasons why reliable diagnosis is important. Now, what's happened to DSM-5? For one thing, the order of the diagnoses has changed pretty dramatically. As a result, now the order approximates the ICD-10 and the ICD-11. And what you'll find when you look at DSM-5 and the chapters in DSM-5, that the disorders that are more frequently diagnosed in childhood appear in the beginning of the manual. These include neurodevelopmental disorders and schizophrenia spectrum disorders and related disorders. And diagnoses that are more common in adolescence and young adulthood, including bipolar disorder, depressive disorder, anxiety disorder, appear in the middle of the handbook. And at the end, the diagnoses of adulthood and later life appear. And that's where substance-related disorders appear, and that's where neurocognitive disorders appear. And those include substance-related disorders that often have a neurocognitive disability. So that's been a change. Another change is there is no longer a chapter on disorders of childhood and adolescence in DSM-5. Instead, disorders of childhood and adolescence occur at the beginning of each of the chapters in DSM-5 if there are childhood and adolescent diagnoses, and they also include several new chapters. So there's no longer an independent chapter that you can go to find disorders usually first diagnosed in infancy, childhood, or adolescence. There have also been changes in the diagnostic system. For example, the multi-axial diagnostic system, which was introduced in DSM-3 and continued in DSM-4, has been deleted from DSM-5. Why is that? Well, primarily because people didn't use it very often, and it turned out not to be able to be used very reliably. So what's happened in DSM-5 is that the axes 1, 2, and 3 of the multi-axial system have been combined, and there are separate notations for what used to be categorized in axis 4 and axis 5. So that's a pretty big change. Well, I've had a change in my system. And I have to do some work here so that I can stay with you. Okay. There's been a very big change in the diagnostic system in that alcohol abuse and alcohol dependence, which are separate diagnostic categories from primarily DSM-3 and DSM-4, have disappeared. DSM-5 asks you to diagnose substance use disorders, that's alcohol use disorders, in a continuum from mild to severe. For example, mild alcohol use disorder requires 1 to 2 symptoms. Moderate alcohol use disorder requires 3 to 4 symptoms, and severe alcohol use disorder requires 5 or more symptoms. Why was that done? Because it turned out that the diagnosis of alcohol abuse did not have a great deal of usefulness. What people were primarily concerned about was which of the diagnostic cues, which of the symptoms appeared and were seen, and how seriously the person seemed to be suffering. And so this move to a single dimension, alcohol use disorder, marijuana use disorder, cocaine use disorder, that would be assessed by the clinician from mild to severe, was thought to be much more useful to clinicians. So let's turn to a more detailed consideration of substance-related and addictive disorders. That's the first major category that we're going to be concerned with, and neurocognitive disorders, which we'll also talk about a little bit. So let's turn to the substance-related and addictive disorders, and in this chapter in DSM-5, there are 10 substance-related disorders, ranging from alcohol-related disorder through tobacco-related disorder and including other substance-related disorders. And almost all of these substance-related disorders include separate categories for substance use disorders, substance intoxication, substance withdrawal. And almost all specify that the substance use disorders be rated mild, moderate, or severe. There are some exceptions because there are a few of these substances that do not include, for example, intoxication. Hallucinogens, inhalants, and tobacco, there is no intoxication to be diagnosed. Caffeine use disorders you don't diagnose according to severity, and the hallucinogen use disorders don't include a category for withdrawal. So let's concentrate on alcohol use disorders because those are the ones you're most likely to encounter. And these include alcohol use disorders, mild, moderate, and severe, alcohol intoxication, alcohol withdrawal, and other alcohol-related disorders. Again, this is, I was a little inaccurate actually. The mild alcohol use disorder, 2 to 3 symptoms, moderate, 4 to 5, severe, 6 or more. And there are 11 of these symptoms, so 6 out of 11, typically in a severe alcohol use disorder where there are 5 or 6 of these symptoms, typically even more than those are included. Alcohol use disorder is a problematic pattern of alcohol use that leads to clinically significant impairment or distress. You notice it doesn't talk about how much is consumed. It talks about problematic pattern, and it talks about clinically significant impairment or distress. And mild alcohol use disorder, 2 of the 11 listed symptoms, and they occur within a 12-month period. What are these symptoms? These will be familiar to you because all but one of them were included in either alcohol abuse or alcohol dependence. So taking alcohol in larger amounts for a longer period of time than intended. So the patient says to you, you know, I really didn't want to drink at this party, but I drank a lot more than I intended. A persistent desire or unsuccessful efforts to cut down or control alcohol use. That's one of the most common. The patient will talk about the inability to control his or her use of alcohol. Spending a great deal of time in activities necessary to obtain alcohol, use alcohol, or recovering from its effects. A new symptom is craving. Strong desire or urge to use alcohol. And that's a very important symptom of quite a number of the other substances. Heroin use disorder, cocaine use disorder, several other of the substances. And craving has turned out to be an important predictor of a condition that is diagnosed as a substance use disorder. Failure to fulfill major role obligations, use despite recurrent social or interpersonal problems, important activities given up or reduced, using alcohol in situations in which it is physically hazardous, like driving while intoxicated, knowing that you have a persistent or recurrent physical or psychological problem, but still using nonetheless. And then tolerance and withdrawal. Tolerance is an important symptom for many of the substance use disorders. And it's defined in two ways: needing to use markedly increased amounts of alcohol to achieve the desired effect. Over time, there's a diminished effect with continued use of alcohol or other substances, and as a result you have to increase the amount of the substance used to maintain intoxication. And that's tolerance. Now, tolerance is a particularly important symptom of the sedative use disorders, barbiturate use disorders. That's perhaps the most important symptom of those disorders. Withdrawal, each of the substances has a characteristic withdrawal syndrome, so that the withdrawal syndrome to alcohol is different from the withdrawal symptom for cocaine abuse or for heroin abuse or for other substances. And as I have indicated, both tolerance and withdrawal are most serious in terms of the sedatives. So that typically a person who is addicted to a sedative like Librium, Valium, benzodiazepines, or the barbiturates, has a very severe withdrawal syndrome and a very high tolerance. And as a result, for the most part, when an individual is addicted to these substances, the benzodiazepines or the barbiturates, they have to be withdrawn in a hospital setting where the withdrawal can be quite gradual. Else, very severe consequences occur that are life-threatening. That's not so much the case with alcohol. It is more the case with the benzodiazepines. Okay, there are specifiers that are used with the alcohol use disorders. In DSM-5, as I indicated, you have to make a judgment about whether you're dealing with a mild, moderate, or severe alcohol use disorder. And you also have to specify whether the patient is in early remission, sustained remission. That basically means he or she has been sober for some period of time, or is in a controlled environment where alcohol is simply not available, in a jail or in a treatment facility, for example. Now, I've indicated that there are 10 substance use disorders. One of the big changes in DSM-5 has been the addition of a non-substance use disorder, gambling disorder. And so the gambling disorder is now included with the substance-related disorders. Now, why is that? That would seem to be counterindicated in terms of tradition. But the fact is that gambling disorder and alcohol use disorder and many of the other substance use disorders share many of the same symptoms. And therefore, the people who created this chapter in DSM-5 added pathological gambling to the substance use disorders because so many of the symptoms are the same, even though obviously gambling disorder does not include necessarily the use of substances. In fact, gambling disorder is very, very often accompanied by well over 50% by either alcohol use disorder or some other substance use disorder. And as with the substance use disorders, when you're diagnosing a gambling disorder, you have to make judgments about severity as a function of the number of symptoms you observe, and that includes mild, moderate, and severe. You also have to specify whether the gambling disorder is episodic or persistent. Typically with the substance use disorders, when it's a chronic disorder, the patient is using most every day. But that's not the case with gambling disorder. A person can gamble intensively one weekend out of the month and not gamble during any of the weeks intervening or any of the weekends other than that one every month. Or a person can be gambling chronically, persistently, and there's no pattern other than that they are gambling many days every month. So those are the substance use disorders, and I'd like to pause and ask whether there are questions about the substance use disorders before I go on to a discussion of the neurocognitive disorders.
All right, so if you have any questions at this time, please go ahead and enter them in that question chat box on your toolbar, and I'll pass those along to Peter.
Okay, so there are no questions. Then let's talk about the neurocognitive disorders. Now, the neurocognitive disorders, that's a new name for the chapter in DSM-4 called amnesia, dementia, and the cognitive disorders. The reason this new label was added or substituted was that dementia had become a stigmatizing condition, and the drafters of DSM-5 felt that it was going to be less stigmatizing by changing the chapter label and removing all reference or as much reference to dementia as possible. This chapter includes Alzheimer's disease, which is typically very stigmatizing, and it includes a number of substance-related disorders as well. So it includes substance, for example, it includes substance intoxication delirium, substance withdrawal delirium, and I will talk about those. What is a delirium? Delirium is different from a dementia. Delirium is an acute disorder, not a chronic disorder. That means that a delirium has a specific identifiable beginning. It continues for a period of time, usually in terms of hours or days, and not longer than that. And it has an ending. It stops, and the person is no longer delirious. Perhaps the delirium you may be most familiar with is the delirium that small children, infants and very young children have when they have very high fevers, so that if their temperatures reach 104 or 105, they may experience a delirium. Another common delirium is associated with the symptoms of AIDS. Typically, if a person is experiencing AIDS, they may also be experiencing one of the symptoms, or one of the set of symptoms may be an AIDS-related delirium. A delirium involves a disturbance in attention and awareness accompanied by a disturbance in cognition. So the person who has, for example, a substance intoxication delirium finds it very difficult to attend to any one thing in the environment, and typically their attention is all over the place. They're unable to pay attention to one specific element of the environment. In addition, their awareness is interfered with. They may be unaware in the midst of a delirium of who they are, where they are, what led them to this delirium. They may be unable to tell the clinician that they've had so much to drink that they've developed a substance intoxication delirium. And there's also a disturbance in cognition, or in thinking. Cognition is a word that means thinking. So individuals in the midst of a delirium are unable to think clearly, and that's why typically their talk makes very little sense. And they will report that they can't think clearly and can't reach conclusions, can't plan their behavior as they are usually able to. Now, diagnosing a substance-related delirium requires that other possible explanations, a pre-existing neurocognitive disorder, for example, or one that's developing, is not a better explanation than a substance intoxication or withdrawal delirium. Sometimes this is very hard to determine because there are other factors that might be leading to delirium in addition to substance intoxication or withdrawal delirium. For example, the individual may be diagnosed with AIDS and may have previously experienced AIDS-related delirium, in which case if you see another delirium, you're not certain, and the person has been drinking, you're not certain whether it is a substance-related delirium or an AIDS-related delirium. So as I've said, substance-induced delirium typically develops over a short period of time, like all delirium, hours to days. It tends to fluctuate during the course of the day. At times of the day it's worse, at times of the day it's better. And these deliria are associated with either intoxication, and that typically occurs when the person has had a great deal to drink. If they have had a great deal to drink, these are relatively unusual, but the person may develop an alcohol intoxication delirium. I was involved in a case of a young man who broke into his neighbor's apartment and thought he was in his own apartment and actually killed the neighbor, believing him to be an intruder. He was in the midst of an alcohol intoxication delirium. He'd had a great deal to drink. He didn't recognize the neighbor. He couldn't think clearly enough to realize that this person was not a threat to him. So he, in the midst of an alcohol intoxication delirium, actually killed the neighbor. And he went to prison for that for quite a lengthy period of time. Now, alcohol withdrawal delirium is familiar to those of you who work with patients who have severe chronic alcohol problems. Alcohol withdrawal delirium is the DSM-5 phrase that includes delirium tremens, DTs. Typically, as you may know, it occurs with, it's a very unusual, relatively uncommon a set of symptoms. It occurs when a person has been drinking typically for many, many years, 20 or 30 years. It is a diagnosis that is pretty much restricted to chronic alcoholism. And it gradually, when the person stops drinking, if they have to stop drinking suddenly, and there is an acute withdrawal, occasionally, not very often, not every time this person would withdraw, but when the person withdraws suddenly, occasionally there will be the development of alcohol withdrawal delirium. And you know the symptoms of alcohol withdrawal delirium. Hallucinations are typical. People see things that pink elephants are a common allusion to this, although doesn't happen very often. But they'll see frightening things. They may hear voices that are frightening, and they may typically will develop severe anxiety and fearfulness. During the period of DTs, they will experience, that's probably the most striking of the symptoms, profound fear, anxiety, fearfulness, and then if the delirium tremens is treated, and typically it's treated by giving the person small amounts of alcohol to stretch out the withdrawal so they're not in an abrupt withdrawal, and at that point the delirium tremens or the alcohol withdrawal delirium will diminish and ultimately end. There is a mortality associated with untreated DTs of 10 to 15%. In the old days, when alcoholics were put in jail to sober up, some of these alcoholics would be suffering from chronic alcoholism, and if they went into abrupt withdrawal, they might develop DTs in jail, and in which case often they would not be treated, and there would be deaths associated with the DTs. That doesn't happen very often nowadays. Typically withdrawal will take place in, if the person is a chronic alcoholic, will take place in a treatment center or some other place where the diagnosis of alcohol withdrawal delirium can occur and DTs can be prevented. Okay, then there are also alcohol-induced major or mild neurocognitive disorders. And that's a pretty formidable label. Alzheimer's disease is a major neurocognitive disorder of aging. So that what we see in major neurocognitive disorder, non-amnestic confabulatory type, is similar in some ways to Alzheimer's disease. The difference is that the alcohol non-amnestic confabulatory type neurocognitive disorder is caused by a symptom, a substance. The substance is alcohol, and it's been consumed on a chronic basis over many, many years. The Alzheimer's disease, major neurocognitive disorder, is almost always restricted to older people who are aged 60 or beyond, and that disorder develops from major brain changes that may be in part genetically determined. So let's talk about the three kinds of neurocognitive disorder that are substance related. Understand that we're talking here about alcohol, but most of the other substances have their diagnoses of neurocognitive, major or mild neurocognitive disorders. Now, the mild neurocognitive disorder that's associated with alcohol has minimal symptoms. They are primarily symptoms of a mild deterioration in cognitive functioning. The individual finds it a little more difficult to remember things, to recognize faces, to plan ahead, to solve problems. And this diagnosis, the mild alcohol neurocognitive disorder, is typically what was diagnosed as sort of wet brain or other mild dementia associated with the chronic use of alcohol. It's relatively common among individuals who have been using alcohol for 10 or 15 years. But it's not nearly as serious, and it does not interfere with functioning to nearly the extent that the major neurocognitive disorders associated with alcohol involve. There are two kinds. One is non-amnestic confabulatory. The other is amnestic confabulatory. The non-amnestic confabulatory type is what used to be called in DSM-3 and DSM-4 alcohol-induced persisting dementia. The person has a severe dementia. They're unable to remember things. They're unable to solve problems. They're unable to think in a meaningful way as they did before. They're typically unable to recognize faces. They may find it difficult to recognize individuals they know very well. But the amnesia part of the disorder is less severe, as is the confabulation part. Confabulation is a word that describes a behavior that is associated typically with dementia, and especially with amnesia, where the individual actually makes up a history and confabulates. It's another word for lying, although the individual is not consciously lying. So what you will find, especially in the amnestic confabulatory type of alcohol-related major neurocognitive disorder, is that the person will confabulate. For example, a person's doctor or nurse will come into his or her room, and the person will not remember that half an hour ago or 2 hours ago or yesterday they saw this person, talked about their condition, the person introduced him or herself, but they will not remember that if they suffer from alcohol-induced persisting amnestic disorder, which is also called Korsakoff's syndrome. So what they will do is to say, oh yes, I recognize you. You were here 2 weeks ago and we talked about the World Series. Well, that didn't happen, but the person is confabulating in an effort to disguise, not necessarily a conscious effort, to disguise their experience of such severe amnesia. So the alcohol-induced persisting amnestic disorder and alcohol-induced persisting dementia are relatively uncommon. Alcohol-induced persisting amnestic disorder is quite uncommon. I think the estimates are that no more than 5% of very chronic alcoholics, people who've used alcohol chronically for 30 or 40 years, will actually experience Korsakoff syndrome. Typically, Korsakoff syndrome is preceded by a week or two of Wernicke's encephalopathy, which is a delirium that involves a disorder of the brain, delirium affecting brain tissue, that ultimately resolves into Korsakoff's syndrome. The Wernicke's disappears, the delirium disappears, and it's followed by a dementia or a major neurocognitive disorder. Okay. The substances that most often, other than alcohol, the substances that are most often associated with major or mild neurocognitive disorder are the inhalants and the sedatives, hypnotics, or anxiolytics. Now, of course, alcohol is a sedative, and it would be included in that category of disorders, but there are hypnotics like the barbiturates, benzodiazepines, the anxiolytics, so the inhalants and the sedatives, hypnotics, and anxiolytics are most common among the substance-induced major or mild neurocognitive disorders. So we talked about the fact that there are alcohol-induced neurocognitive disorders. There are 4 symptoms for both of them, and both have specifiers. The symptoms include a significant cognitive decline from a previous level of performance, substantial impairment in cognitive function, which interferes with independence in everyday activities. They don't occur exclusively in the context of a delirium. They're not better explained by another mental disorder. And the mild neurocognitive disorder, mild cognitive decline from a previous level of performance. It does not interfere with independence in everyday activities, doesn't occur in the context of a delirium, isn't better explained by another mental disorder. So I would be happy to respond to questions or comments about any of the things that I've talked about thus to this point. I thank you for your attendance, and if anyone has any questions, I would be happy to respond to them.
Well, thank you, Dr. Nathan, very much for your presentation and sharing your expertise with us today. We have had our first comment come in, and they say, just a thank you. I enjoy the historical perspective included. Our next question is, do you have any recommended tools for familiarizing?
I'm sorry, could you repeat the first question?
Yeah, the first question is just a comment.
Okay,
So it's just a thank you. I enjoy the historical perspective included.
thank you very much. Second question.
Second question, any recommended tools to familiarize oneself with the new diagnoses?
Well, there is a manual written by a fellow named, a psychiatrist named Donald, Karen, who's the person in the Department of Psychiatry?
Donald
Remember,
Black.
Donald Black. And this is a relatively short introduction to the new DSM-5. And I think it would be worth going online on the American Psychiatric website and looking at that particular manual. That would be a way to acquaint yourself in particular with the co-occurring disorders that typically accompany alcohol use disorders and other substance use disorders. As you know, typically those disorders include depression, anxiety, schizophrenia, and the manual will talk about changes. There have been changes in those categories as well, and that might be worth your while.
Thank you. Our next question is, what do you see as the future for the DSM-5?
Say that again. What do I see
As the future for the DSM-5?
That's a very good question. There's been severe criticism of DSM-5, much more severe than any of the other DSMs. My guess would be that there will be a relatively short period of time before a revision of DSM-5 is instituted. But I can't say for sure, but I know that that there have been many criticisms. They've been very severe, very persistent, and so I think something has to be done. I think the credibility of DSM-5 has been impaired.
Thank you. Okay, our next question is, in the DSM-4 diagnosis was made through the axes, so 1, 2, 3, etc. What is the new format to document the diagnosis in the medical record?
Well, that is probably, I don't know the answer to that. I don't think that's necessarily been worked out. The multi-axial diagnostic system has been dropped because it turns out it was unreliable. I would guess there will be a development. In fact, I think there's been an effort in DSM-5 to develop an alternative system that is more reliable. The question is whether, in fact, it is more reliable. And I think if you look at if you buy the DSM-5 manual, there is a section on recording diagnoses for medical records, and the question is whether it's going to turn out to be sufficiently reliable, more reliable than multi-axial diagnosis was. So I don't really have an answer to that. I think it remains to be seen how that's going to work out.
Thank you. Well, I'm not seeing any more questions at this time, so I think we'll go ahead and wrap up our session. So once again, I'd like to thank Dr. Nathan for sharing his knowledge with us today. I'd like to remind everyone to please watch for our email with handouts for this webinar. Your attachments will include the CEU request form and the PowerPoint handout, as well as a link to our customer satisfaction survey. We do appreciate if you decide to complete that survey, as completion of these surveys allows us to show SAMHSA the number of people who were served by our webinar. To participate in the survey, just please follow that link in that email. We hope that you'll be able to join us for our next webinar in this series, 50 Shades of Developing Gray Matter, on November 6th, where Ken Winters will be presenting on adolescent neurobiology and marijuana use. We also hope that you will be able to join us for our next webinar in our Essential Substance Abuse Skills webinar series on October 16th on group counseling. So finally, I'd like to just thank all of you for your time participating in today's session. We hope you enjoyed the session, and we look forward to hearing your feedback. Thank you.